All right. Hey, Huzi.
Hey bud, how you doing?
Good. Today I wanted to talk about mechanical ventilation and ARDS.
Awesome, dude. Let's do it, but just don't mind the mess in my room, okay? Like all you see, just ignore it, please. So, what do you want to talk about?
Yeah, so I kind of wanted to know about like mechanical ventilation studies and how to think about them.
Yeah, dude, completely agree. So I'm sure you already know one of the mainstays of mechanical ventilation for ARDS is making sure you target that 4 to 6 mils per kg of predicted body volume to prevent lung over distension, and that's derived from the ARM trial. So the ARMA trial that helps reduce alveolar stretch and improves the survival overall. That's the trial was from 2000.
Yeah, and if you look at the ARDS.net, they have charts. And a lot of adjusting the tidal volume also involves adjusting the PEEP or the positive end expiratory pressure. It's crucial. And you kind of adjust it based off of lung compliance because the formula is compliance equals volume time over pressure. So given a constant lung compliance, you're adjusting the PEEP so that you get the tidal volume that you want.
Uh-huh.
And high PEEP equals improved lung function, especially in patients with lower PF ratios, which stands for PaO2 over FiO2. But it's important to keep plateau pressures low to avoid lung injury.
Good point, man. With the plateau pressures, you want to keep them below 30 centimeters per of water. The reason is that minimizes the risk for lung injuries. And also, you want to at the same time focus on driving pressure because think about it, your lungs weak at that time, so you don't want to push too much pressure in. So stay below 14 centimeters per water, as that's known for better outcomes.
Yeah, and how are we evaluating how good we're doing every day? We're setting oxygen targets with the pulse ox of 88 to 95. And when we do ABGs or arterial blood gases, we want to see the PaO2 between 55 and 80 mmHg. Some people have looked in the past about doing recruitment maneuvers, except that's phased out of favor, and we use them more cautiously now. And they temporarily improve lung compliance and gas exchange, but they come with risks like barotrauma.
That's a good point. One thing that has kind of popped off is prone ventilation, especially for severe ARDS. I think it started more commonly in Europe, but now it's kind of coming into the States. Sessions of proning, and literally as it sounds, placing the patient in an anatomical prone position. And the sessions will last about 16 hours, enhances oxygenation, reduces ventilator-induced lung injury. But you got to be careful of pressure-related injuries. There's such issues with aspirating and however beds are not basically designed for some people to lie flat and can be very uncomfortable.
Nice. And then esophageal pressure monitoring is also valuable too, and they can be used to guide PEEP adjustments and optimize transpulmonary pressure. Non-invasive ventilation can be useful, but we need to monitor closely. There's this thing called helmet NIV, and they may have better outcomes than face masks. But we also must be vigilant for signs of NIV failure.
That's a good point, man. And then obviously, ARD is still such a difficult thing to manage. The severe cases don't respond to conventional strategies. You can talk about ECMO, but that's really been shown to also help patients who have more reversible conditions and are younger.
And they've also looked at fluid management too, comparing people with conservative fluid management versus those not. And conservative fluid management has been shown to reduce the duration of mechanical ventilation in ICU stay. Generally, aiming for lower pulmonary artery wedge pressures correlate better with survival.
That's a good point, man. Yeah, but the last thing you want to do is give our patients with ARDS flash pulm edema. I mean, ultimately, these strategies are just like the bare basics of it, and there's a lot more to do with improving patient outcomes. But using these, you can definitely start understanding the mech ventilation goals for our patients with ARDS.
Yeah, thank you for joining us. Stay informed and stay safe.